We distinguish between common types of uncomplicated and complicated intra-abdominal infections and listed common microorganisms associated with intra-abdominal infections. Now, given a patient with an intra-abdominal infection, let's recommend appropriate treatment. Let's take a look at treatment of some uncomplicated intra-abdominal infections. These are in the absence of peritonitis. For pyogenic liver abscesses, essentially surgical drainage plus empiric antibiotic are recommended. And for monotherapy, essentially piperacillin-tazobactam or a carbapenem, including erdopenem, is recommended. For most patients, piperacillin-tazobactam is the way to go. For patients who are at risk of resistance, then carbapenem. When there is a need for ESBL coverage, erdopenem is the drug of choice. For combination therapy, instead of piperacillin-tazobactam, we may use either a third generation or a fourth generation cephalosporin plus metronidazole for bacteroides coverage. Obviously, piptazo and carbapenems do cover bacteroides, so there is no need to add metronidazole to carbapenems or piptazo. Alternatively, ciprofloxacin or levofloxacin or moxifloxacin could be used in combination with metronidazole. Now, parenteral treatment for 2 to 3 weeks is recommended, and then a 4 to 6 weeks total course is completed using oral agents. So in general, duration of treatment for pyogenic liver abscesses could be quite long. For uncomplicated acute cholecystitis, cholecystectomy is effective treatment. Antibiotics should be used before and at the time of surgery, essentially for surgical prophylaxis to prevent surgical site infection, but not indicated post-operatively. So essentially, once the gallbladder is removed, there is really no need for antibiotics. For uncomplicated acute cholangitis, decompression or drainage of the biliary system is the effective treatment. Empiric antibiotics may be used and treatment for 4 to 7 days once source control is obtained. When it comes to diverticulitis, essentially surgical intervention is recommended, and essentially the sections of the colon that have these diverticula will surgically be removed, and then the end of the colon will be attached. So essentially removing the segment that was surgically removed, and the site where this is reattached is essentially, the terminology is reanastomosis, and antibiotics may not be necessary for this patient. Outpatient oral treatment for 7 to 10 days has been suggested, but it is not clear if there is a benefit to giving these outpatient antibiotics. For uncomplicated acute appendicitis, again, appendectomy is a very effective treatment. Alternatively, patients who do not want to get appendectomy, they may receive either IV antibiotics for 10 days or initial IV transition to PO antibiotics. And recommendations include erdopenem, combination of cephalosporin plus metronidazole, or oral fluoroquinolone plus metronidazole. Once the patients have received surgical intervention, there is really no need for antibiotics post-operatively. Now, for complicated intra-abdominal infections, one thing that's key is to identify patients who have high risk for failure of source control. There are several risk factors for this. The most important are delay in the initial interventions, more than 24 hours, or a high severity of illness using the Apache 2 score. The Apache 2 score essentially, the higher the score, the higher the risk of mortality. Advanced age is defined as age over 70 years old, or if the patient is immunocompromised, and there are a few other risk factors on the list. So when it comes to treatment of extrabiliary complicated intra-abdominal infection, essentially you need to think whether the patient has high risk for failure or so if the patient has any of those risk factors, they will be considered high risk. Otherwise, the patient will be mild to moderate with no risk. So if there is, mild to moderate severity, there is no need to cover Pseudomonas. So monotherapy includes either, you essentially want to cover E. coli, Klebsiella, and Bacteroides. So cefoxitin monotherapy, erdopenem monotherapy, or tigecycline monotherapy, or a combination of either cefazolin plus metronidazole or cefuroxamine plus metronidazole. Essentially some cephalosporins plus metronidazole or a fluoroquinolone plus metronidazole. Now, for high risk, essentially Pseudomonals needs to be covered. So the monotherapy options includes piptazo or a carbapenem that covers Pseudomonas specifically. And for combination therapy, it's something that covers Pseudomonas, cefepime, ceftazidime, cipro, or levo, plus coverage for Bacteroides. So metronidazole will be added. Now, for community-acquired complicated intra-abdominal infections, when we look at acute cholecystitis, again, we look at those risk factors, so high risk and mild to moderate severity. So mild to moderate, again, there is no need for Pseudomonal coverage. So cefazolin, cefuroxime, or ceftriaxone. Now, for cholecystitis, there's no need to cover Bacteroides specifically for these mild to moderate severity patients, and obviously no Pseudomonal coverage. For high-risk patients, there is a need to cover Bacteroides as well as Pseudomonal. So piptazo, carbapenem, cefepime plus metronidazole, or a fluoroquinolone plus metronidazole. When it comes to treatment of complicated cholangitis following bilioenteric anastomosis, one thing that's different is that it doesn't matter if it's mild to moderate or high risk. Essentially, all patients need to have Pseudomonal coverage, but also they need MRSA coverage. So vancomycin should be added to any of these agents. Now let's take a look at some recommendations. So for anaerobic cultures, essentially anaerobic cultures are not necessary if empiric antimicrobial therapy is active against common anaerobic pathogens. For high-risk patients, cultures from the site of infection should be routinely obtained, particularly in patients with prior antibiotic exposure who are more likely than other patients to harbor resistant pathogens. As mentioned before, ampicillin-sulbactam does not have good activity against E. coli, so therefore, it is not recommended. Aminoglycosides are not recommended essentially because of toxicity, and we have many other agents that can be used. In general, empiric coverage for enterococcus is not necessary, even though enterococcus is isolated in many of these intra-abdominal infections. Again, enterococcus, belongs to the normal gut microbiota. Now, occasionally patients may grow candida on these cultures in intra-abdominal infections, and that may not necessarily be causing an infection. So empiric antifungal therapy for candida is not recommended. Fluoroquinolones should not be used unless antibiograms indicate more than 90% susceptibility to E. coli. Aspirin plus metronidazole is an alternative, but addition of an agent effective against gram-positive cocci is recommended. So remember, metronidazole and aspirin have absolutely no gram-positive coverage. Now, empiric use of agents effective against enterococci is recommended for community-acquired high-risk complicated intra-abdominal infections. Use of agents effective against MRSA or Candida is not recommended in the absence of evidence of infection due to such organisms. And lastly, antimicrobial regimens should be adjusted according to culture and susceptibility reports to ensure activity against the predominant pathogens isolated in culture. Now let's take a look at spontaneous bacterial peritonitis. So essentially the diagnosis is based on acidic fluid analysis showing PMN of at least 250 cells per cubic millimeter or more. Now, older AASLD guidelines also had mentioned that if the PMN is less than 250, but if the patient has either a fever or abdominal pain, that also is diagnostic of SBP. For treatment, essentially an IV third generation cephalosporin is recommended. Most often people use ceftriaxone because of easier dosing. It can be dosed once a day. And that's for community-acquired SBP. For healthcare-associated SBP, it is important to use a local antibiogram to make sure that we use an agent that's appropriate. Often, piperacillin-tazobactam may be necessary. And vancomycin should be added if prior MRSA infection or a positive surveillance swab for MRSA is found in the patient. In the case of VRE, instead of vancomycin, daptomycin should be used. For, if the patient has had a recent exposure to piptazo should be replaced with meropenem. In critically ill patients, it is recommended to use carbapenem-based therapy as opposed to starting with piptazo. And total duration of antibiotic use for treatment of SBP should be 5 to 7 days. Now, what about preventing SBP? So there is the concept of primary prevention of SBP. So this is someone who has never had the SBP before. So we're trying to prevent this for the very first time. And certain patients qualify for primary prevention. The most, the biggest one is essentially patients with cirrhosis who have upper GI bleed. And when they have that GI bleeding, because that can lead to SBP, it is recommended to give IV ceftriaxone for up to 7 days. Now, other patients, cirrhotic patients who have low protein ascites, primary SBP prophylaxis can be considered if they have renal dysfunction. So, for example, serum creatinine greater than 1.2, BUN greater than 25, or serum sodium less than 130, or if they have liver failure. And the agents for primary prophylaxis for these patients essentially is ceftriaxone, but trimsulfa and ciprofloxacin have also been used. These are all for 5 days. So essentially, prophylaxis from GI bleeding is a bit longer compared to other types of primary prophylaxis. And then once somebody has had SBP and received treatment, then you can do secondary prevention. So secondary SBP prophylaxis is to prevent other SBP occurrences. And unfortunately, these patients who have had SBP, they don't live very long. So their life expectancy is quite short. So these are very difficult to study. So when you see this recommendation, they say indefinitely, but keep in mind that these patients may not have many years left to live. So ciprofloxacin daily is recommended, and as you can imagine, this is going to have a huge effect on causing collateral damage. So people have also tried by mitigating it by using ciprofloxacin once a week instead of daily, and also there has been rifaximin at 400 milligram TID dosing, which is not in the guideline, but people have studied this and have tried this. This is more expensive, but it could be beneficial in patients who have E. coli resistant to ciprofloxacin or Bactrim. This concludes this presentation.